Stanford Conversations in Menopause and Healthy Aging, the podcast, a trusted science-backed resource in menopause and healthy aging. When it comes to your medical and health education, tune in and submit your questions to world-class leaders in medicine and research. Stay informed, stay empowered, because your health matters.
Hello and welcome back to Stanford Conversations in Menopause and Healthy Aging, the podcast about living well through perimenopause, menopause, and beyond. I'm your host, Dr. Karen Adams, board-certified OBGYN and lifestyle medicine physician and director of the Stanford Program in Menopause and Healthy Aging. At Stanford, we've created the Menopause Collaborative of Practice, a group of leaders in women's heart health, bone health, brain health, breast health, and more. All the things that add up to healthy aging. I'm asking those colleagues to join me on this podcast to get good information to you, the women who are going through it. Today's topic is women's heart health. Super important topic. Although my patients mostly worry about breast cancer, we die of heart disease. And the changes that happen in menopause can increase our risk for heart attacks and strokes and cardiovascular disease. I am so pleased to welcome today's guest, Dr. Eleanor Levin, to the show. Dr. Levin is a member of our Stanford Menopause Collaborative Group, and she's a clinical professor of medicine and a preventive cardiologist. In this two-part series, Dr. Levin and I will talk about how women's hearts are different from men's, how menopause affects our hearts, and what we can do to keep our female hearts healthy. Welcome, Dr. Levin. I am so happy that you're joining me today.
Thank you, Dr. Adams. I'm happy to be here.
Okay, let's dive in. So why don't we start with you telling us a little bit about your practice? You're a preventive cardiologist. What kind of patients do you see?
Well, I see all kinds of patients. Part of my practice is cardio-obstetrics. So I see women with heart disease in pregnancy and after pregnancy. That's a small part. I've done that for decades. I do general cardiology where I see patients with arrhythmias, valvular disease, all kinds of heart disease. And principally, I do prevention, secondary prevention after someone has had bypass surgery or angioplasty or heart attack with coronary disease, and some primary prevention in high-risk patients with lipid disorders or a strong family history of heart disease.
And how long have you been in practice?
I've been in practice since 1989.
Oh,
So
my.
quite a while.
You've seen a lot of changes in your field, I'm sure.
Oh, tremendous changes. Yeah, it's been really fun. Really great.
Right. How do people get to your clinic? Can they refer themselves or do people get referred in?
Well, most of the patients get a referral in to general or preventive cardiology or cardio-obstetrics from their primary care physician, or in cardio-OB, it's from their obstetrician. There are a few people who self-refer because they know they're at high risk or they're worried that they are with lipid disorders or other reasons to see me.
Sure. That makes sense. So what are the main conditions that you see in midlife and older women? What are the kinds of things that your patients are coming to you about?
Well, what happens after menopause is when you don't have protective hormones is generally the lipid panel, the cholesterol goes up. And the good cholesterol, or HDL, that works as the vacuum cleaner to vacuum up the bad cholesterol, becomes more dysfunctional. So even though you might have a very high good cholesterol, it's not sweeping up the bad cholesterol. And so women tend to get more lipid problems after menopause. Another thing that happens is at some point in our lives, we all get high blood pressure. And this tends to accelerate after the menopause as well. A lot of this can be mitigated by lifestyle changes, but some of it's genetic.
Mm-hmm. Right. And what I tell my patients is when you go through menopause at any age, that happens. You know, your HDL becomes less functional, your LDL goes up, your blood pressure goes up. And so even people who are going through menopause early because of various medical treatments or surgeries, things like that, we see those changes. So it's really about menopause, not about a particular age, which I think is super interesting.
Well, it's also more risky for your heart the
Hmm.
earlier you have menopause. So people who have premature menopause, and particularly surgical menopause, before the age of 45, need to be on hormone replacement or they're going to have very premature heart disease.
Right. Oh my goodness. Such an important point. You know, when you go through menopause under age 45 and certainly under age 40, that risk really accelerates because some people don't go through menopause until 55 or 58, and you've had another 10 years of good heart health until you've gone through that process. And if you're, unfortunately dealing with menopause at age 37, that's really significant. And so I think that's a really important point to bring up. Heart health, bone health, brain health, all kinds of things are impacted by that.
And what I find also among my colleagues is people are accustomed to replacing the estrogen at postmenopausal levels. But when you have someone who has an abrupt surgical menopause and is not a breast cancer survivor, they need to be replaced at a higher level, adequate for their usual age. And that's something people need to take into consideration.
Oh my goodness, so true, so true. It's the only time we actually really follow estrogen levels, estradiol levels with that treatment. We don't do that in normal postmenopausal people after age 50 or so, but we certainly do in those younger women because we have to push those levels up in order to reach a point where they have heart and bone and brain protection. You know, so that's just such an important point. Yeah.
Mhm.
So before we start talking about specific advice for women's heart health, let's just take a step back and let me ask you, broadly speaking, is women's heart health different from men's?
Well, the difference, there are a few differences. But if we go first by age of onset of coronary disease, for example, women tend to get it 10 years later than men. So they tend to get it more around 50 or 60 instead of 40 or 50. And that's if they're protected by their hormones until menopause. The other thing is women have a couple of conditions that can happen to your coronaries, which happen in men but are much more specifically dangerous in women. And that is broken heart syndrome, which is stress cardiomyopathy. And also, they tend to get more coronary spasm causing a heart attack. And then there's also coronary erosion. So those three types of coronary disease, as opposed to the standard ruptured cholesterol plaque you see in men and in women after menopause, you can see in younger women that can cause a heart attack.
Hmm. Talk to me a little bit about broken heart syndrome. That is stress cardiomyopathy. What can you explain what
Yes.
that is?
Well, you've always heard you're telling your teenager, stop that or you're going to give me a heart attack. And
Hmm.
it's totally true.
Oh my.
So, stress cardiomyopathy is about 2/3 women, 1/3 men. It's about 2/3 with an emotional stress and 1/3 with a physical stress. And it causes heart dysfunction and can look exactly like a coronary heart attack. But when you do a test of the function of the heart with an echocardiogram to look at how the walls are moving, they don't move in the areas based on arteries. So it's something caused by an adrenaline surge from stress, and it is just as dangerous as having a coronary plaque event.
My goodness. Oh my goodness. So interesting. And what about this spasm that you mentioned? That is something kind of more unique to women as well?
Well, women tend to get it more than men, just as women tend to get more migraines than men. So I tell my
Mm.
patients it's like a migraine of the heart. So the coronary artery won't necessarily have a lot of cholesterol plaque in it, but it will damp down and spasm, and it will cause in an arterial distribution a heart attack. Now that can be improved by medications
Mhm.
and prevented by medications.
Hmm. Similar to migraine medication or something?
Well, a little different. We tend to use calcium blockers
Hmm.
with coronary spasm, and they do use those to prevent migraine, but they have other specific migraine medicines, and also they have used beta blockers more often. And
Mhm.
beta blockers are not really indicated to prevent coronary spasm. So the medications are different.
I see. I see. You know, you've been practicing for a while. Were you trained to think about women's hearts differently than men's? Was that part of your training, or is that something you've
That
come?
was not at all part of my training.
Hmm.
In fact, I would say in the beginning, the cardiologists that I first trained with and then worked with were very confused when they saw women who had a heart attack and then they do a cardiac catheterization and there was no cholesterol plaque and
Hmm.
they tended to be younger. And they would keep telling them there's nothing wrong with you when there was something seriously wrong, and sometimes even death. So what happened as I went into practice, less than 5% of cardiologists were women at that time. And of the patients coming in who had these confusing syndromes,
Hmm.
I ended up seeing those patients. So I ended up seeing the patients that we now call broken heart syndrome, that we now call coronary spasm, that we talk about dissection, coronary artery dissection called spontaneous coronary artery dissection, or SCAD. I saw
Mhm.
those women after, mostly after pregnancy. And so I ended up getting, and cardio OB, because the men didn't want to see anyone who was pregnant. They just told them terminate and go away.
Hmm.
So I ended up getting a lot of those patients, and that's how I developed the experience over decades before there was such a specialty as women's heart health.
Right, and now we just know so much more that I think it's much more understood that women often present differently when they're having a coronary event or something, and that I've heard that even as a gynecologist, that it's often not the chest pain and the jaw pain and the running down your arm and the kind of things that we were trained to look for. So that's a
Well, in
really important
particular, it
perspective.
could be pain going to your upper back. It
Mhm.
could be pain in your abdomen, right below your sternum. I would say that it is more typical when you're in your 60s, 70s, and 80s, when the estrogen levels have gone down. But the heart attacks in younger women can be these other entities like stress cardiomyopathy, spontaneous coronary dissection, or coronary erosion, those different things.
So let's talk about how you approach general heart health with your patients. You're a preventive cardiologist. How do you have that conversation with patients about lifestyle and things that are impacting their heart health? We know we have genes. We have to play the genetic cards we're dealt. We can't really impact that, but we can impact a lot of other aspects of our heart health. So how do you talk to patients about that?
Well, I think the first thing we do is take a good history. We take an exercise history, how many times they exercise per week. Is it cardio? Is there strength training? We take a dietary history. How many servings of vegetables are they eating every day? Whole grains? How many servings of meat or chicken per week? Alcohol is very important. The World Health Organization now recommends no alcohol for heart health. The Canadian Heart Association recommends 2 drinks or less per week. And that's because alcohol, besides causing 7 kinds of cancer, including breast cancer, of course, is also associated with atrial fibrillation, an arrhythmia that causes stroke, cardiomyopathy, which is a weak heart muscle if you drink every day for more than 20 years, these sorts of things. So I take an alcohol history very carefully. And then we do want family history. Another important thing is what was their OB history. If they had preeclampsia, eclampsia, gestational hypertension, or gestational diabetes during any of their pregnancies, 10 to 20 years later, that makes them at higher risk for a standard cardiovascular event. And then we need to know what their cholesterol panel is and what their liver function is. Because if your cholesterol is high for many years, you can actually get fat in the liver. And that is the major cause of liver transplant at Stanford. It's fat in the liver. It's not alcoholism.
Hmm. Oh my. I think we're becoming more and more aware of the impact of alcohol all the time. We've got some very prominent leaders in medical care across the country and around the world saying there really is no safe level. There's no, people will sometimes say to me, well, where does the level start to get risky? It's like there's really no level that isn't
Yeah, but I
risky.
do talk to people that I think if you enjoy wine, for example, or alcohol, to go with the Canadian Heart recommendations, which is about 2 drinks a week,
Mhm.
which for women is a smaller dose than for men because they metabolize it differently. So for wine example, a serving for men would be 5 ounces. A serving for women is considered 3 ounces.
Mhm.
Beer for men is about 12 ounces. For women, it's 8 ounces.
Mhm.
So to try to reduce to about 2 drinks a week. And there are
Yeah.
many non-alcoholic options now, non-alcoholic beer, non-alcoholic wine, mixed drinks with seltzer water and fruit juices. So people can still be social and reduce their overall alcohol intake.
That's, I think, such a great point. There's more and more options available that are non-alcoholic, and you can even just put it in your wine glass and have
Yeah.
that experience of it. The other thing I know we've talked about before is one of our colleagues is an expert in the science of behavior change, and she says good enough is always perfect because if we try to achieve perfection and we say, I'm never going to have another glass of alcohol for the rest of my life, you're setting yourself up for a very challenging rest of your life if you enjoy a glass of wine with dinner. So maybe you save your 2 glasses for the weekend or
Yeah.
however you figure out a way to make that work for yourself. And that's good enough. I
Yeah,
think
I think
that's,
so.
yeah. So, one of the questions I hear a lot from my patients, and I wonder about this, is supplements for heart health. People are wondering, is there anything they should be taking? Should they be taking omega 3s? Should they be taking red yeast rice? Should they be taking turmeric or other things? How do you think
Okay.
about that
I
with your
have a
patients?
lot of strong ideas about this. First of all, the Journal of the American College of Cardiology did a review about 4 years ago of all the evidence. So if we start with the positive evidence, Vitamin D was safe and healthy as long as it's not too much. And vitamin D levels can be checked if you like to take vitamin D supplements. Women in postmenopause are more often vitamin D deficient than they are overdosed on vitamin D. And if your vitamin D level is extremely low, you'll have lots of aches and pains and fatigue. And I have seen this. So consider vitamin D. We often give CoQ10 when we take a statin, and CoQ10 was one of the supplements associated with increased longevity in this article. So I don't discourage CoQ10. Turmeric, it turns out recently turmeric supplements have been associated with liver failure, and that's not from the turmeric itself. It's from the substances put in the pills, because the pills are not FDA supervised and approved. So if you like turmeric, use it as a spice. Don't take it as a supplement. Now, fish oil, as one of your omega-3s, has been popular for years, and there's actually a prescription fish oil, and that has had some benefits, and especially in the case of people with pattern B hyperlipidemia, where their triglycerides are very high and their HDL is very low. However, all of the studies have shown a signal for atrial fibrillation with fish oil. So if you do not have high triglycerides, and particularly if you have risk factors for atrial fibrillation, which include sedentary lifestyle, overweight, hypertension, or family history of AFib, I would not encourage fish oil for you. If you want an omega-3, use flaxseed oil. So far, there's no data showing that causes atrial fibrillation. The B vitamins are interesting. B12 has been encouraged from UCLA because of a dementia study that it improved mild cognitive impairment. Certainly, if you're vitamin B12 deficient, you should supplement. If you take chronic acid blockers like PPIs, like Protonix or omeprazole over the counter, you should take B12. It's very difficult to overdose on B12, and you can get deficient, and this can cause nerve pain, sometimes permanent, in your feet. The other B vitamins were tested in something called the Swiss Heart Study for people with elevated homocysteine, because that was felt to be a risk factor for coronary disease. But the Swiss Heart Study using B vitamins to lower the homocysteine was negative for positive effects on coronary. So we're not encouraging excessive vitamin B supplements for this reason. Vitamin C at doses more than 500 per day has been associated with atherosclerosis. So I don't particularly encourage vitamin C, but if people are taking vitamin C, I encourage them to reduce it to 500 a day. Are there any other supplements you're interested in?
Red yeast rice?
Oh, red yeast rice. Please don't use it. Red yeast rice is a form of statin. It's like lovastatin, our oldest statin, only it's not regulated by the FDA. It has more side effects. We don't know how much you're taking. It could affect your liver. Just take a statin in a pill if you need it, but do not use red yeast rice. If you want to add something that's natural to lower your cholesterol, you can use plant sterols. That's recommended by the American Heart Association. There are plant sterols in Benecol margarine, and that is very safe. Another thing that's natural that reduces cholesterol is psyllium. Metamucil was the original branded psyllium, and taking psyllium every day can reduce your LDL cholesterol 5 to 10%. Any other supplements?
That's so helpful. So vitamin D, possibly, especially if you're having joint pain, maybe vitamin B12, CoQ10, possibly, flaxseed, not
Yeah,
fish oil, and possibly plant sterols. Am I
correct. And
hitting the ones
psyllium,
you suggest? And
psyllium, which is
psyllium.
a soluble fiber. We also discourage vitamin E because it can cause increased bleeding and it interferes with the
Mhm.
other medications that we give. Because we often, when people have significant calcification in their coronaries, we give aspirin. And so you don't want additional blood thinners like vitamin
Mhm.
E. So we discourage
Mhm.
vitamin E.
Such an important point because people think if you buy it off the shelf somewhere, it's safe and it's not going to interact with anything else, but it absolutely can. And often things are not regulated and there's not batch to batch consistency. So we always come at this from a lifestyle perspective. Eat the rainbow, eat lots of fruits and vegetables, that sort of thing, and not popping 20 pills of supplements a day is probably a
Yeah.
safer and
The
better way.
recommended diet is the DASH diet,
Mhm,
DASH, Dietary Approaches to Stop Hypertension. And it's a diet very like a Mediterranean diet, but without the alcohol,
mhm,
and lots of fruits and vegetables, whole grains, a little bit of fish and chicken, and not much red meat.
mhm. Right. And is there any kind of an exercise prescription you give to your patients for heart
Yes,
health?
absolutely. We would like them to exercise 30 minutes a day minimum, to shortness of breath, but can still talk. That's on a relative perceived exertional scale of 1 to 20. It's about a 13. It's not horribly hard. It's not horribly easy. If you don't make yourself a little bit short of breath, you're never going to get better.
Mhm,
We also encourage strength training 2 or 3 times a week. There
mhm.
should be no breath holding, no Valsalva. That's not good for your blood pressure or your brain. We encourage light repetitions. You can use a machine or you could use weights. 1 second up, 2 seconds down, no breath holding.
Great, great. So strength training is just as important for heart health as aerobics. Is that correct?
Correct.
Hmm. Great. And we love strength training for all sorts of reasons. And so that's a great message. I always learn so much when we chat, Dr. Levin, and I am so glad we're talking about this because it literally impacts every woman who is listening to this. And you can improve your heart health at any age. It is never too late to start. And so this messaging, I think, is super important. So thank you so much for being with us today.
Thank you.
So please join us for part 2 of our 2-part series on heart health, where Dr. Levin and I talk about menopause and hormone therapy and how it impacts our hearts. Thank you so much for joining us on Stanford Conversations in Menopause and Healthy Aging. We will see you next time.
If you've enjoyed this episode of Stanford Conversations in Menopause and Healthy Aging, please take a moment to follow or subscribe to our podcast on your favorite platform and consider leaving us a rating or review. It's a simple, zero-cost way to support our work and help others discover the show. You can also stay connected with us on Instagram, YouTube, and other social media at Stanford Menopause. For additional resources, event notifications, and other updates, be sure to visit our website, menopause.stanford.edu, where you can also sign up for our program newsletter. Thank you for joining us, and most importantly, thank you for your interest in advancing the conversation around menopause and healthy aging.